So thank you all for joining this session on headache disorders. We're going to have a focus on migraine, but we'll be discussing other headache disorders as well. Migraine, of course, is the headache problem that brings patients to the physician the most often. Now, there are about 4.5 million people with migraine in Canada, so you can see this is a huge problem for our society, and overall it causes a lot of disability. So it's really important that headache properly diagnosed and managed as well as possible. So we have 3 speakers today who will be addressing various topics related to headache and to migraine. I'll be the first one, and I'll give a short presentation. And then I'll introduce our other 2 speakers when their time comes. And at the end, we'll have a question period. So please do stay tuned for the questions, and don't forget to send your questions to questions@painab.ca. So I'll start by introducing myself, and I'm going to just start to share my screen here as well, if I can do this successfully. So there we go. So I'm Werner Becker, a neurologist in Calgary, and currently a professor emeritus at the University of Calgary. When I first came to Calgary in 1978, I was impressed with how many headache patients were coming to a general neurologist like me for help, and also how complex it was to try to help some patients with difficult migraine and other headache problems as well, because they really needed a comprehensive and complicated management plan. And then I became very interested in migraine in about 1990 when I was involved in some of the first clinical trials with sumatriptan. At that time, it was obvious that there was a whole new class of migraine medications coming along, and that migraine science was getting pretty exciting. And I decided to develop a major interest in headache at that time. It was a very exciting time. Now, as we've heard from Dr. Dodick this morning, there have been many headache advancements since then in headache therapy. And I've been lucky over the years to have been involved in most of the research programs to some extent that brought these new medications on the market and made them available to patients. Now, it seemed clear to me over the years that although medications were getting better, patients with migraine needed more than that. And I once heard this expressed as the saying that it takes more than a molecule to cure migraine or to treat migraine. And I thought that migraine patients might do better with an organized program, so they could benefit both from the new medications and from behavioral approaches to help them manage their migraine better. And so in 2003, I organized the CHAMP headache program here in Calgary, which brought together several different disciplines to help give migraine patients a more comprehensive approach to their management. The CHAMP program is still active today, and in fact, you'll be hearing from Dr. Lara Cook later on in this session, who currently directs the CHAMP program, and several neurologists in Calgary now work in that program. So I'm going to move on now to give a brief a lecture to start our program off. It'll be quite a short lecture, but it has a very long title. The title being Acute Medications for Treating the Migraine Attack, a brief overview of the past, the present, and the future. So with that, I'll proceed. And here are my disclosures. I do consulting work for a number of industry companies that are developing headache medications. Here are the objectives, and we're going to basically discuss a little bit about the evolution of how migraine medications for treating the acute attack have come on over the years, how they've been developed, and we'll discuss the current state, the current situation. So let's take a brief look at the past. We'll go back to Dr. John Graham, who was probably America's first headache specialist. We're going back about 60 years now. And back then, Dr. Graham had a number of analgesics or painkillers available to him. He had caffeine, but also very important, he had ergotamine, which seems to have been actually his main migraine medication. At that time, ergotamine had been around for 40 years. It was not a new drug. And Dr. Graham had a very long section in his book that he published back in 1956 on how to use ergotamine as well as could be done. Now, Dr. Graham did recognize that using ergotamine frequently could in fact make migraine attacks more frequent, a condition we now call medication overuse headache. So if we fast forward 30 years, Dr. Neil Raskin published a book in 1988 where he discussed the state of the art of headache medicine at that time. And again, today we're talking acute treatments. These are treatments for the individual migraine attacks. We're not talking about preventive therapy where patients take medication daily or take injections every month to prevent some of their attacks. Now, Dr. Raskin, 30 years later than after Dr. Graham, he still had a number of analgesics. He had acetaminophen now as well, or what's not often now referred to as Tylenol. He had caffeine, and he also had two new drugs. He had ibuprofen and naproxen. Now, these are non-steroidal anti-inflammatory drugs. We may refer to them as NSAIDs from now on to keep it short. They were a useful addition, but one of Dr. Raskin's main medications was still ergotamine, the old drug from 1918 and even before that in terms of herbal preparations. And Dr. Raskin, again, had a big section in his book on how to use ergotamine as well as could be done. And of course, Dr. Raskin and Dr. Graham both had a big problem. That is that many patients just can't use ergotamine because it causes too many side effects, especially nausea. That was a huge problem. And Dr. Raskin also recognized that ergotamine taken too often could cause medication overuse headache, make migraines more frequent. He also recognized that in addition, taking analgesics too frequently, even aspirin or acetaminophen, could also make migraine attacks more frequent. So let's fast forward now another 30 years to the present. And what's the situation currently in Canada? Well, we still use the NSAIDs, ibuprofen and naproxen. We have diclofenac as well now, and we still have ASA. These have all been shown now by good clinical research to benefit many migraine patients, although certainly not all. The big change is that we now have the triptans. And in fact, we have 7 available in Canada, and I've listed them here. And these are all available in an oral tablet form. And in fact, they do help many patients. And the big difference between the triptans and ergotamine is that the triptans have a lot fewer side effects, and most patients can take them. They don't work for all patients, but they work for a very significant proportion. So that's a big advance. And in fact, the triptans are generally so much better than ergotamine that ergotamine is no longer available in Canada. So a sea change, if you will. Now, if we need to, we can combine the triptans and the NSAIDs to get more effectiveness for patients. So that can be a helpful strategy. We can also add the antiemetics, metoclopramide and domperidone, if patients have a lot of nausea, and it can also help to make the other medications more effective. Now, a major change here is that you may have noticed that Dr. Graham and Dr. Raskin both had codeine on their list of analgesics for migraine. We now discourage the use of codeine because it doesn't work very well for one thing, but also it's a real cause of medication overuse headache if patients take it too often, which is often the case. So codeine is really kind of off the list for treating acute migraine attacks. Now, the irony of the whole thing is that the ancient ergotamine and the triptans really work by the same mechanisms. They both come in and agonize or activate the 5-HT1D receptor on the pain nerve endings in the trigeminal nerve inside the head that are innervating blood vessels. And this action upon the 5-HT1D receptor blocks the release of neurotransmitters from the nerve ending, especially CGRP, calcitonin gene-related peptide, and this helps to stop the migraine attack. Now, the triptans also activate, like the ergotamines, the 5-HT1B receptor, which is on the blood vessels in the head and causes vasoconstriction. How important the vasoconstriction is for stopping the migraine attack isn't totally clear. It was thought to be very important at one time, but I think now it's considered to be much less important. The big thing is probably blocking the release of these neurotransmitters from the pain nerve endings. So ergotamine in a way led to the triptans, but the triptans are much better drugs. So what is the triptan secret? And I'm showing you that here. As you can see, ergotamine activates the important receptors, the 5-HT1B and 1D receptors, but it activates a host of other receptors as well, which I'm not even showing here, all of them. So it's a pretty dirty drug. Whereas the triptans, here, for example, sumatriptan, activates the important ones, the 5-HT1B and 1D, but doesn't activate too much else. Some triptans also activate the 5-HT1F receptor. We'll mention that a bit later. But the point is that the triptans are much more specific, much cleaner medications than ergotamine ever was, and shows you what science can do, what migraine research can do in terms of refining medication treatments for migraine. So the question arises, which triptan is the best triptan? And if you look at some of the meta-analyses that have been done comparing the various triptans as best we can, given the research data available, it does seem like elatriptan and rizatriptan usually come out a little bit on top, as measured by the proportion of patients who are pain-free at 2 hours. It's not a huge difference in most cases. And the fact is that every migraine patient seems to have his or her individual chemistry. So it's not uncommon for migraine patients to very much prefer another triptan other than those two because they feel it works better for them or causes fewer side effects. So really the best triptan is the one that works best for the patient. And this best triptan may differ from patient to patient. So there's still a bit of therapeutic trials involved in trying to find the best triptan for any given patient. Now, what I've shown you so far relates to the oral tablets for the triptans. But triptans do come in other forms as well, and this is important to understand if you're treating migraine patients. For example, we only have one injectable triptan, sumatriptan, which is injected subcutaneously by the patient. And this, in fact, this is the best triptan in the sense that it really produces a pain freedom in the most patients of any triptan formulation. A lot of patients don't like injections, but it's a good thing to have in your back pocket for those patients who really need it. We also have a 𝐒𝐿matriptan nasal spray, for example. It's available in Canada in a 5 milligram dose. And this can also be very helpful for many patients. It's absorbed through the nasal mucosa to some extent. So therefore, even if patients have quite a bit of nausea, it can be useful. We have diclofenac potassium, a non-steroidal anti-inflammatory drug, which has been produced in an oral solution, which gets absorbed very quickly through the stomach. So it's one option for patients who need to have relief in a hurry and still want to take something by mouth because it's absorbed very quickly and can work very quickly. And then we have ketorolac nasal spray, which according to one clinical trial, it seems to be pretty effective. And again, it's a nasal spray, so it's not a tablet. Unfortunately, it's not commercially available in Canada. If you want to use it here, you will have to ask a pharmacist to compound it. So a brief word on the future. I'm sure you all recognize this Cybertruck. The Cybertruck is now a symbol of the future. Dr. Dodick already has discussed some of this, so I'll be fairly brief. Lasmiditan is coming along. It's actually available in the US currently. So the future comes sooner south of the border than it comes north of the border. It still hasn't made it to Canada. This is a drug which is a new class. It does not cause vasoconstriction because it doesn't work on that 5-HT1B receptor, or the 1D for that matter. It works on the 5-HT1F receptor, another serotonin receptor, which seems to have the ability to relieve migraine attacks. So the fact that it's not a vasoconstrictor means that it's okay for patients with vascular disease, unlike the triptans, which are contraindicated in patients who have vascular disease like heart disease or previous strokes. And to make a long story short, lasmiditan seems to be about as effective as the triptans. If you look at this graph, these bars here show 2 clinical trials for lasmiditan. The dark bar is placebo. The lighter orange bar is the active drug, lasmiditan. And you can see that the difference between placebo and the active drug is about 20%, almost 20%. So lasmiditan does seem to make about 20% more patients pain-free over and above those who become pain-free at 2 hours from placebo. Now, as Dr. 𝐒𝐂𝐑𝐈𝐁𝐄 mentioned this morning, this drug does enter the central nervous system. It's lipophilic, and so it does cause some central nervous system side effects, in particular dizziness and somnolence. It's a minority of patients, fairly small minority, but it's significant. The dizziness often is not severe, although occasionally it may be. So patients will have to be warned about this. And an interesting wrinkle in new medications nowadays is that in the US, as Dr. 𝐒𝐂𝐑𝐈𝐁𝐄 mentioned, I think if a drug seems to affect the central nervous system, it has to be tested in terms of whether it causes driving impairment. And lasmiditan does. So after taking a dose of this, it seems that some patients, perhaps most patients, have some impairment in their driving ability for a number of hours. So another issue with this medication, now we have to wonder, of course, how many of our old medications cause driving impairment. Back then they weren't tested, but this is now something that we have to discuss with our patients with lasmiditan because it's been demonstrated. So the last thing I want to mention are the GPANs, these small molecule receptor antagonists. Once again, the future has come sooner south of the border. 𝐒𝐿 and 𝐕𝐵 are both available in the United States. Neither one is available in Canada, so it's still the future for us. This is an interesting group of chemicals. These drugs are CGRP, or calcitonin gene-related peptide receptor antagonists. They block the receptor. Over history, 7 of these have been developed and tested. And you'll notice in this slide that, in fact, the development of 4 of these has been terminated. Now, the main reason for that was liver toxicity, which was especially notable with 𝐒𝐿-𝐂𝐵, the second last drug in this list, which was actually a very promising acute migraine medication. And we were all very sad when that drug development program had to be discontinued. Now, here again is where science and research really come in. And it's interesting because here's the 𝐒𝐿-𝐂𝐵 chemical formula. And the chemist went to work and did a little surgery in this molecule. So you can see now that 𝐒𝐵, one of the newer GPANs, has a few things missing and a few things added. And with these changes, voila, it no longer causes liver toxicity, no longer an issue, it seems, but still seems to do the good stuff and help migraine. Now, I have to admit that looking at these new medications, both 𝐒𝐵 and 𝐕𝐵, look at the clinical trials, it does seem like the therapeutic gain over placebo is fairly small. You'll notice here that placebo made about 12% of patients headache-free at 2 hours or pain-free at 2 hours, and 𝐒𝐵 made about 22% pain-free. So that's a difference of around 10%, whereas for lasmiditan, it was almost 20%. So it may be that these drugs, the GPANs will basically help fewer patients than lasmiditan will. I guess time will tell, but the therapeutic gain of these medications seems to be less than for the triptans or for lasmiditan. Having said that, they do seem to be relatively free of side effects, although Dr. 𝐒𝐂𝐑𝐈𝐁𝐄 mentioned that in practice, they may have a few more side effects than we thought from the clinical trials. That's not unusual. So in conclusion, I'll just say that today, the triptans and the NSAIDs, the non-steroidal anti-inflammatory drugs, are still the mainstay of migraine acute attack therapy. It's quite remarkable what migraine research has done for us over the last several decades, and I think it'll do even much more in the future. And we mustn't forget that there are formulations, for example, for the triptans that go beyond tablets. We have injections, we have nasal sprays, we have orally dissolving tablets, and these may be helpful for many patients and should be considered. Lasmiditan will be a major advance, I think. Have to be careful with the dizziness and driving impairment. And the GPANs look promising. And although their therapeutic gain over placebo may be smaller than the older drugs, they're not vasoconstrictors, so they're safe in patients with vascular disease, and they may well be beneficial for many patients.